Hello, hello, hello. Welcome, everybody. What a cool song. I love that song. Classic 90s alternative, the best era of music, in my opinion. Thank you, Mr. Producer, for that lovely drag out. Happy Friday, everybody. It is the end of the week, and we got the comfy chairs today. So I'm real happy about that. We get to sit back, have a little fireside chat, except I don't have a fire today. It is actually warming up outside, finally. That's all fantastic. I know my pain patients really appreciate some good, nice, warm weather. So today, wow, we're still digesting all of the cool stuff that our hosts have been able to help us go through and understand this week. All the way from Jose, basically emphasizing, hey, you know what? Like sometimes by protecting your pain, it's going to make it worse, right? Sometimes by guarding your movements, which is natural, nobody wants to hurt intentionally, but we can actually make things worse if we don't just push through it just a little bit. Smartly, of course. And then Kate is giving us some examples on, hey, the tests all come back negative, but you're still having pain. Maybe it's because you're not being tested on the right thing. Maybe there's some microbiome going on, some troubles with your gut bacteria, some things that maybe need a different test to evaluate, or maybe a different intervention to help bring some truth to you. And then, of course, Keith last night. Wow, I'm always impressed by Keith, because, again, I think that speaking on things from this side of the fence, so to speak, from the physician side of the fence, I know that my patients put up barriers, even despite my best efforts to break them down. It's just part of the system. I know my patients maybe withhold information or say things in a way that maybe they want me, or they think that I want to hear. And, I hope that you don't do that. If you are a patient of mine and you're watching this, be open and honest, be comfortable. I can promise you, I'm going to do the same thing. But even still, the dynamic there is such that I don't always get the picture. And that's what I appreciate about hearing Keith and hearing all of you, respond in the chat. I've been learning so much. Really the importance of getting a diagnosis, right? All your tests are normal, and how that must feel, pretty demoralizing, I can imagine. And so, coming up with different ways that we can speak, right? The purpose of today, not only to recap all of that, I want to take it another step, take just one more little step forward. What happens when somebody tells you that your tests are normal? What is the next step? And I think that's the pendulum that I want to highlight today. We talked about it a little bit on my show on Monday, some of those studies, and I was kind of reviewing that again and realized that, well, that was probably a lot of information that may be a little bit hard to digest. So we're going to make it a little more bite-worthy today, okay? So just bear with me. How you doing back there?
Hey, I'm doing okay.
Welcome to the show.
Well, thank you for having me.
Yes, Evelyn is in the chat today, so don't hesitate to reach out, say hello, and throw out your questions so we can all learn something here together, because I'm focused on you guys. It's hard for me to do two things at once. I'm going to take you back on a little journey. Little 12-year-old Dustin, way before he went to medical school. Although he did know he wanted to be a doctor. Don't ask me how I knew. But anyway, little 12-year-old Dustin woke up one morning. It was Tuesday. The sun was out. It was beautiful. Clear skies. Go downstairs, get ready to go to school. I was in 7th grade. And I walked into the kitchen. And I looked out the window, got some Honey Nut Cheerios, poured them in my bowl, a little bit of 2% milk. That's what my mom bought back then. I'm a whole person milk now. Maybe Katie can weigh in on that. But anyway, I made my little bowl of Cheerios, turned on the little TV, which was this big, on the kitchen counter. And I saw 2 big skyscrapers. One of them was on fire. And I was like, what is this? 12-year-old me didn't quite understand any of that. I've never been to New York. So I changed the channel. I'm looking for cartoons. Give me something good before I go to school. But it was on the next channel and the next channel. And I was like, man, what's going on? Whatever. I guess I'll just sit here and watch this. So I'm trying to sit there and comprehend what's going on. And then I walk into my mother's bedroom, and my parents are in there watching the television, their mouths on the floor. And as we're sitting there, the second plane comes and hits the other building. So, as a millennial, that was my first sort of like awakening moment. Wow, okay, maybe the world isn't as safe as I once thought it was. Maybe the world is not as truthful as I once thought it was. There's bad people out there. And I think as a millennial, maybe many of you will agree, who are in my generation, we're sort of primed to go through life asking questions. Yeah, but what's really going on, right? Yeah, I know that's the case, but what's actually going on behind the story? The risk, of course, is that you are thrown out of society as some sort of crazy conspiracy theorist. The challenge that I have to that, it seems, as in recent days, all of these conspiracy theorists are being proven right. To some extent, I don't know. I'm not the judge and all that, but it's pretty crazy what goes on. And of course, healthcare is really no different, right? We're often told one thing, and it's actually another thing entirely. Kevin, what's that clip? My favorite clip with one of the best hip hop artists of all time.
You got me.
Okay, well, he'll have to think about that. Don't believe anything you see on the news, Kevin.
Correct.
He'll pull that up here in a minute. But that's the truth, right? I always ask, should we believe what is on the news? Should we not believe on the news? Or is it, why is it that they want us to believe what's on the news? That's the question. Not is it true or not, but why do they want me to think it's true? And I think that's sort of the theme, is like, how can we get to the bottom of what our doctor is telling us, what healthcare people are telling us, what the studies show? Where's the momentum? And then why is that momentum there? So let's pull it back. I'm going to go all the way back to 1980. There's a famous study, and study is actually not even the right word. It's a letter to the editor, Porter and Jick. Kevin, why don't you pull up that first slide, Exhibit A. I want you guys to check this out. You probably already know, those of you who have read about chronic pain in popular books, and what's that one book? Dreamland by Sam Quinones. Fantastic book. He goes over this quite extensively. This is a study published in the New England Journal of Medicine, 1980. Addiction rare in patients treated with narcotics is the beautiful, sexy headline. Under the editor's note, we're going to come back to that. You'll see there at the bottom, to the editor. This is a 5-sentence letter. Recently, we examined our current files to determine the incidence of narcotic addiction in nearly 40,000 hospitalized medical patients who were monitored consecutively. Although there were nearly 12,000 patients who received at least one narcotic preparation, there were only 4 cases of reasonably well-documented addiction. 4 cases in patients who had no history of addiction. The addiction was considered major only in 1 instance. The drugs implicated were meperidine in 2 patients, Percodon in another, and hydromorphone, which is Dilaudid, in another one. We conclude that despite widespread use of narcotic drugs in hospitals, the development of addiction is rare in medical patients with no history of addiction. So this letter was then cited nearly 500 times. Pull up Exhibit B again for me, Kevin. This letter was cited nearly 500 times over the next 2 decades. And what you see here is the number of citations in various publications. I'm sure not all by physicians per se, but I'm sure a lot of them were physicians. The dark blue are the affirmational citations, meaning that they agreed with the conclusion of this letter, this 5-sentence letter to the editor. What's interesting is about all of that, approximately 80% of them had no idea or did not cite in their affirmation that these were hospitalized patients. They did not know that. They did not realize that this was not a randomized controlled study. They did not realize that this was for acute pain and not chronic pain. They did not realize that it was outpatient, long-term management of opioid therapy versus inpatient, where every pill is controlled. How do you even diagnose addiction in a hospital? You got to be there for probably a month, at least, I would think, in order to like get to that point where somebody says, hey, I think we have a problem here.
Pretty much.
So, it's nonsense. And I have a lot of, I put a lot of blame on the physicians for overlooking this or promoting it, which is what 80% of people did on those 500 citations. And then guess what happens? Big Pharma gets a hold of this. 1995, the makers of OxyContin. As you can see, this was the peak, 1995, 1996, 1997, of the citation of this. And they were like, hey, going from doctor's office to doctor's office, check out our beautiful pain medicine for beautiful pain medicine for pain management. And here's our study. It shows that it's non-addictive. Like 3 patients and 40,000. Whoa. Okay. And then we got to a point in 2012 where doctors were writing so much opioid that every patient in the country had at least 1 bottle of opioid on their kitchen table. Were we any better off in 2012 as a pain patient? I don't know. I know a lot of people were harmed. Tens of thousands, hundreds of thousands over the years. So that's what happened. So then we had a pendulum swing where there was zero restriction on it, and we were citing ridiculous studies with sexy headlines. And then we came all the way to the other side where now it's all in your head. You don't need opioids, and you just need something else. Maybe psychological intervention. Well, now different people are hurting. Has the addiction rate gone down? Maybe slightly. But that's not the point. More people are hurting now. More people are struggling to get access to real pain management, whatever that looks like. More people are being gaslit, just in a different direction. How do I know all this? Well, I'll tell you why. Because there's the best pain study that's ever been published. I'm about to show you. We actually talked about this on Monday, this study. They did a 5-year follow-up, and I guess it's an opinion piece here published in Pain Medicine News, December 9, 2025. Groundbreaking study. Shows that pain reprocessing provides durable reductions in chronic low back pain. Fantastic. Tell me more. So, again, this is a 5-year follow-up to the original study published in 2022 in JAMA, where they noticed significant reductions in chronic back pain. Roughly 2/3 of people who underwent pain reprocessing therapy became pain-free or so even a year later. This was the 5-year follow-up. Show me the next slide, Kevin. Let's see what people have to say about this. So at the top of here, you see pain reprocessing therapy. So the idea is that, as I mentioned on Monday, we're ignoring back pain as far as tenderness on physical exam. We're ignoring scoliosis. We're ignoring spondylosis on an MRI, meaning that you have arthritis, you may have disc problems, but as long as they're not like severe, whatever that means, I'm doing finger quotes right now, we're gonna disregard that as well. So actually, all the pain is in your head, and you're gonna go and believe that you're gonna do therapy now that the pain is actually, Kevin, I think the camera battery may be low. Don't worry, he's got another one. The pain is actually coming from up here. It's because you believe that it's fear. You believe that if you move, it's going to hurt. You believe if you move, it's going to injure you, and you're fearful of this, and so it spirals you down into this negative place where you perpetuate your back pain. So if we can change the way you think about something, the back pain will go away. That is great in theory, and I am sure that it's going to be great for the right patient. But let's look at what the numbers are. At 5 years in the treatment group, we had 21 participants who were almost or entirely pain-free at 5 years, compared with 10 in the placebo group and 13 in the usual care participants. So again, 10 in the placebo, they had an injection of saline into their muscle, into their back, okay? And then 13 didn't do anything different. They were just the typical chronic pain patient management type situation. Still 13 were pain-free at the end of 5 years, is fantastic. So yes, the study here does show to be good, but let's keep reading. What did they actually talk about? Dr. Mark Sullivan, a professor of psychiatry and behavioral sciences at the University of Washington School of Medicine, says it's an impressive, groundbreaking study. John Sturgeon, PhD, concurred that this was, quote, a very significant advance in behavioral treatment for pain. What we don't know is how much these effects generalize to other groups with chronic pain, which is true because the participants in this study, on average, had a pain score of about 4. Most of them were mobile, and none of them had sciatica, meaning, pain shooting down the legs. So it was really pretty chronic, mild, non-debilitating type pain in their back. Who doesn't have some extension of that, right? So I give them credit for at least saying that we don't know about how these effects generalize to, actual people with pain. Let's read the last sentence on there, Kevin. Sturgeon found it remarkable that almost 2/3 of patients in the treatment arm were essentially pain-free, a feat he described as exceedingly rare. It might be the most successful pain treatment study that has ever been published. Wow. Well done. Well done. See, that's the problem I have with the study. The study is not bad on its own if you recognize it for what it is. But when we start getting things like, hey, addiction is rare. Hey, this is the most successful study ever. You don't need traditional management of your pain. You don't need medication or injections or even physical therapy. You actually just need to believe that your pain is better. And that just makes this fantastic. So I was like thinking to myself, man, but everything I just said right now, it's kind of hard to swallow. It's kind of boring. It's kind of like, how can I make this interesting for you fine people on my YouTube channel? Well, I was looking at the numbers again. Now remember, 21 people did very good with the psychogenic treatment. 21. 13 did really good with just doing pretty much nothing. So that difference, that delta, is 8 patients. This is the most successful pain study because 8 more patients did better than doing nothing at all. Now, I know statistics, and it's not just about numbers, it's about proportions and all these things, but at the end of the day, it's still 8 patients. So how can I make this understandable for you? Kevin, hit the music.
They called it groundbreaking, put it up in lights. 5-year follow-up, cue the victory bites. Telehealth talking, reframe your fear. Your spine's just fine, it's your brain, my dear. Low pain and bold, your every week. MRI glowing, science looks sleek. They said durable, said profound. darling, count this out loud. One arm says 55%. Crowds go wild, headlines get bent. But when you strip the noise away, there's a number left that won't behave. 8 patients, that's the margin they're celebrating. 8 patients, groundbreaking population. 8 patients, cue the praise, cue the stations. 8 patients, sing it slow. 8 patients, placebo did fine. Usual care too. The mind-brain shift stole the view. Blame-free stories, press release glow. Ignore the overlap down below. No sciatica, no severe disease. Active folks already on their feet. They say most successful ever made. Thanks to the Delta, you could misplace. Functional gains, belief correction, but belief ain't anatomy detection. You can call it central, call it kind, but numbers still gotta clear the line. 8 patients, that's the win they're elevated. 8 patients, statistically serenaded. 8 patients, whole new theory, same limitations. 8 patients, say it again. 8 patients. Not saying minds don't laugh, not saying fear ain't real, but pain ain't solved by vibes alone, and p-values don't heal. Durable belief made so durable for crane. That's the rest. When 80% already trained, that's not your average test. Now sell it as a paradigm shift for packets. Or no, give it a lift. New name, same frame, same refrain. If it didn't work, blame the brain. They'll say this doesn't generalize. Try after calling it revolutionize. And somewhere out there, someone heard. Outside the demo, outside the charts. 8 patients, say it soft, say it blatant. 8 patients, that's the difference, that statement. 8 patients, science or celebration. 8 patients, mic drop. 8 patients.
I couldn't say it better myself. Oh, AI is something else, man. I'll tell you what. It's true. It's 100% true. It's nonsense. It's laughable. It's a joke. It's a joke. And the joke is that it's the most successful pain study ever published. I'm in pain management. I read a few studies. That's a joke. Sorry. It's not a bad study on its own. If you accept it for what it is, it's not a bad study. It's actually a really good study if you accept it for what it is. The problem that I have with it is the gaslighting. It's the movement behind it. It's, hey, again, we don't need to do exams. We don't need to do MRIs. We don't need to do injections and medication management and all this other stuff, right? It's just up here. Well, my favorite line from that, if you have a favorite line from it, put it in the chat. Mine is, vibes don't treat your pain alone. It's not, you need more than vibes. Vibes are good.
My favorite is 8 patients.
Yeah. Vibes are good. You need good vibes. We know this. It's not the only study to say, hey, bad vibes mean more pain. Good vibes mean less pain. That is true. But is that how we should be prioritizing our pain management?
And everything on 8 people.
You know,
for the whole population.
It's ridiculous.
For 40 years.
Right.
Amazing.
Right. So that's sort of the lesson, how you can tell that maybe there's something else going on. And I think, I'm not here to promote opioids as the treatment. I'm not here to promote psychogenic interventions as the treatment. I think when you're promoting just one, there's an agenda, and it's not your pain relief. If all you're doing is promoting opioids over every single thing else, you don't care about pain management. You don't care about the patient. And the same thing is true if all you're promoting is non-opioid treatment. And I will say that. And by the way, that goes to doctors too. If I'm a patient, I want to throw everything in the kitchen at it. I don't like to be in pain. And so if psychogenic therapy works for you, then you should have the insight. And I hope you have the insight, and your physician should have the insight to set you up with a qualified professional to take you down that road. It works for it worked for 21 patients in this study. What am I doing right now? I'm keeping it in perspective. And that's what we have to do. Keep everything in perspective. Is everybody who gets an opioid immediately addicted to it and selling it on the streets? No, of course not. Are most patients very responsible with their medication? And do they get excellent relief and quality of life and ability to function? Yes, absolutely.
I would assume so. I mean, if you're in pain, what are you going to do?
Does everybody? No.
I would hope so.
No,
I can understand the situations where there may be the onesie twosies that slip through the cracks. Someone gets the meds from the kitchen sink or the bathroom sink or whatnot, but
right.
Blanket rule for the entire population.
Well, that's my point. Not everybody's going to do great with every treatment. We know this. We've been talking about this whole time. Whether it's opioids or spinal cord stimulators, which I learned is probably one of the more controversial topics in pain management, and perhaps rightfully so. But a lot of people do really, really well with it. Really, really well. Not everybody. So that's the point. I think if you can have an honest conversation with yourself about everything and anything that's out there to help with your pain, and your doctor's willing to go down that road with you, then that's a good doctor. And, actually I was talking with Keith last night, this idea of, well, maybe I need to get acupuncture. I was like, yeah, that's great. I don't offer acupuncture. I'm not trained in it. I don't have anyone on staff that can do it. But your doctor should be able to help get you set up with somebody or allow you to go outside of their, plan of care to find something that can work. If you don't offer it, then be open to things that can help your patient out. That's the whole point. So, that's sort of what we're trying to do here is, again, empower our patients, right? My goal as a pain management and a rehabilitation physician is to make my patient not dependent on me. I want them to graduate out of my clinic. I want them to get back to life. I don't want them to feel like they have to come and see me every month and do the same rigmarole just to get by in life. If that's what it takes, that's what it takes, and that's what we're here for. But the goal is to get you to a point where you don't need to see a doctor. And I think that's a little antithetical to, again, the healthcare system at large, because the system is creating dependence. And I've talked about that a little bit too. I think the future is headed much more towards preventative medicine, which is, a good thing. If you need healthcare, then you need healthcare. There's nothing wrong with that. But again, my role is to get you to not need me. And that's why, man, heaven's going to be fantastic.
Right.
I'm going to be out of job.
Oh, yeah. Jamie, I like how you put this in the chat. He has, I don't know if Jamie's a male or female here, so forgive me. But with purpose, for a purpose is how I use my drugs.
With purpose, for purpose.
With purpose, for a purpose.
Yep.
I thought that was pretty cool.
Exactly. Yeah. That's what they're there for. And don't get me wrong, I'm not demonizing any particular treatment. What I am trying to call out is the gaslighting of really not that great studies as they're being tried, they're being pulled into changing paradigm shifts for treatment plans.
Right. Just
like Porter and Jick did in 1980. Now, to their credit, and also maybe to the credit of the current authors of the study I mentioned, they are being honest about what the study shows. It's the reaction that the study can create that we all have to be wary of, right?
Is that really being honest, though? 8 people?
So, actually,
is there
can you pull up the I think it's Exhibit C, the first, the one with all of the highlighted pictures. So I want to show you this too. You know what's crazy about this?
The one with the graph?
The last one.
Got it.
With all the words. It's not even really just 8 patients. That's giving the study credit. So in the treatment group, 21 participants were almost or entirely pain-free at 5 years, compared to placebo and usual care. So if you didn't get the treatment, then you were more likely to be almost or entirely pain-free at 5 years, because 10 plus 13 is 23. So, again, the best study ever. Just call it for what it is.
Mm-hmm.
It is cool that they did a 5-year follow-up. I mean, I'll give them that. That is not very common in pain studies for such a long follow-up. But again, that doesn't necessarily suggest that as a culture, as a pain management movement, we need to be suggesting that, well, I'm sorry that you have back pain, but there's nothing we can do, and you just need to go and see a shrink. I think a psychologist or a psychiatrist should perhaps be a part of your plan of care, but again, it's an ingredient. I like to say it's part of a complete breakfast.
No different than the milk.
You need the milk, you need the Cheerios, and hopefully something better on TV.
Cartoons.
Some dark humor for you. What's going on in the chat tonight?
Well, everybody loved the song. We had Keith said he hates his medicine. He hates meds. He feels like they're a leash, and he wish it could make sense. And Jamie says, I understand the hate, but is it really the drug that you hate, or is it the system? I believe drugs are neutral, and it's how we use them that can help harm.
Yeah. Wow. I don't know how you do it. I mean, I can't take a vitamin every day.
I don't remember.
To be truthful, and I guess if I had excruciating pain that I couldn't move with.
Right.
And, and then there's a stigma that everyone around me sort of sees. My family members always, why is Dustin always out there taking his vitamins?
Mm-hmm.
They don't understand.
Or frantically looking for your vitamins like you're looking for your keys.
Right. No, I get that. And, I think it's for some patients, it's similar to needing oxygen to live. Mm-hmm. People have lung problems and COPD and asthma, and they need oxygen to keep alive. And I imagine that would be a very difficult thing to deal with. The good news is it is keeping you alive. So hallelujah for that. We'll take what we can get, right? If only the stigma was not there, just like with oxygen. There's sympathy for oxygen. That people don't understand the same.
Because everybody needs it.
Yeah. So everybody needs oxygen. So yeah, guys, next week we have a big week next week. It's all about motivation. And sometimes motivations can be skewed. They can result in effort that maybe is misplaced. Sometimes the more we try to fix something, the harder we hammer something, the worse things get. Actually, Monday, I think my discussion is going to be a little bit more geared to physicians, providers. But I think even as a patient, you're going to appreciate it because it's going to give you a little bit behind the scenes of maybe what a physician's motivation is, what they're up against, and maybe why things don't always seem so fair to you, coming at it from the other perspective. So we're going to continue learning. We're going to continue hopefully making the world a better place. Again, we're not here to fix your problems. We're here to help you fix your problems because we don't want to be a barrier between you getting back the independence that you deserve. Have a great weekend. Learn something about God. We'll come back Monday. Until next time, see you later.